Dr. Deepak Kumar from Department of General Medicine, and I will going to discuss on today's CGR on Anti-Microbial Stewardship Program, and which we have just initiated in our institute also. So before going to discuss about AMSP, we have to know some common definitions. I think everyone is aware about what is antibiotic, what is antimicrobial, and what is antimicrobial resistance, which is, I think, it is a very growing concern in nowadays. But what is antimicrobial stewardship? Basically, it is a coherent sets of action which promote the responsible use of antibiotic. And what is antimicrobial stewardship program? That it is health care strategic implementation of AMS with the help of evidence-based intervention. So basically the AMS is the practices and implementation of these practices is AMSP. The objectives of the AMSPs are that improves awareness and communication and education regarding the antimicrobial resistance, strengthen and acknowledge the surveillance, reduces the infection by promoting the infection prevention practices, optimizing the use of antibiotics in human as well as the animal by using antimicrobial stewardship practices, and finally lead to the health and economic impact on the country. So these are the main three pillars of antimicrobial stewardship program. The first pillar is antimicrobial stewardship. The second pillar is infection prevention practices, and third is diagnostic stewardship. So today we'll discuss about the antimicrobial stewardship, because IPC, I think every healthcare person which is joining our institute are get trained about the IPC practices. And regarding the diagnostic stewardship, the role of both clinician as well as the microbiologists come here. That clinician have to send all the relevant sample so they get early etiological diagnosis, and they can minimize the use of broad spectrum antibiotic, and they can use a definitive therapy. So today we're going to discuss about the AMS. The antimicrobial stewardship having three pillars. The first pillar is to know the antibiotic resistance pattern of AMR of our area or our patient. Second, formulation of the local as well as the national guideline for use of the antibiotic. And third is to measure the impact by calculating the antibiotic use by use of some simple formulas like DDD, daily drug doses, and DOT, duration of the therapy, as well as impact on the morbidity and mortality of the patient. So we'll discuss all three pillars one by one, so we can incorporate AMS, how to incorporate AMS in our patient services. So the two things is very important to know to proceed in the AMS. One is the etiology and second is the drug. The etiology is basically bacteria, and we have to have good knowledge of the drug means antibiotic. So when the bacteriology come in the mind of clinician, the book come in the mind is that the book of microbiology. They have a long list of bacteria that contain 10, 20, 15 bacteria, and they are going to be adding more and more bacteria. So clinician is thinking that there is a lot of bacteria, so we have to give one antibiotic that can cover all the bacteria. But this is not true for clinical practice, and actually I have realized that the 5 important bacteria can cover 95% of the bacteriology for the clinician. These are the first is the E. coli, second is the Klebsiella, third is the Acinetobacter, fourth is the Pseudomonas, and fifth is the Staph aureus. I think the whole bacteriology is completed for the clinician with only getting the knowledge of 5 bacteria. We need not to be a knowledge of all the bacteria which is written in the textbook of the microbiology. So if clinician can know about these 5 bacteria, the bacteriology in the hand of the clinician. And this is the WHO priority list of the bacteriology, and we can see here the first is Acinetobacter, Pseudomonas, Enterobacteriaceae means E. coli, Klebsiella, and Staph aureus. These are the bacteria that actually creating the problem in the management of the patients and drug resistance. So we'll discuss with the case and how to incorporate the AIIMS practices on the case-based discussion. So it is a 72-year-old male presented in the emergency with a history of fever for 4 days, burning, micturition and left flank pain, associated with nausea and vomiting. And he is known case of diabetes, coronary artery disease, hypertension, is taking regular treatment, and diabetes is under control. On vital examination, patient having tachycardia and slightly lower blood pressure with high grade temperature, but still maintaining the saturation. And the preliminary investigation which was done in the emergency, that showed neutrophilic leukocytosis, and the urine is full of the pus cells. I think the diagnosis is quite obvious, and this is in case of complicated urinary tract infection. Then the question comes, which antibiotic should be given in this patient? So what are the type of antibiotic which we are using in the practices? They are the prophylaxis, there is a definitive therapy, or empirical therapy, like in our patient we are going to start. So there is a definitive guideline for the prophylaxis use of antibiotic as well as the definitive use of antibiotic. But the empirical antibiotic we have to select very wisely. And we have to keep these core competencies before prescribing the antibiotic. The first is understand the patient and patient clinical need. Mean actually the patient is require the antibiotic or not. If patient require the antibiotic, then understand the treatment options and how they support the patient's clinical need. Like in our patient, yes, in a case of UTI, definitely it requires the antibiotic. And then understand the treatment option. What are the treatment options available and how it support the patient's clinical need. Work in the partnership with the patients and other healthcare professionals, especially the microbiologist and as well as the laboratory persons. Communicate the treatment plan and rationale clearly to the patient as well as the other healthcare professionals. Not that we have to select this antibiotic because we are using in every patient. We have to very clear about selecting the antibiotic. And then further, we have to monitor and review the patient response to treatment so we can taper down the broader spectrum antibiotic to the smaller spectrum of antibiotic. And finally, we have to prescribe a right drug in a right dose, in a right route for the right duration in a right patient. And this is the main motto of the AIIMS. So we will back to the case, how to select an optimal antibiotic in our case. So we can follow some simple 4-5 steps and we can able to select the antibiotic. First is the severity. Actually our patient is severe. So severe patient is always require IV therapy rather than the oral therapy. Second is the source. So what is the source? The source of the infection in our patient is the UTI. So we have to think what are the common etiology of UTI, and the common etiology of UTI in I think our region is E. coli. Then we have to know the drug resistance. So we have to know what is the pattern of drug resistance in the E. coli. The two type of drug resistance could be there. One, if patients already is suffering from the recurrent UTI or any infection, and patient already had some report that having some antibiotic sensitivity pattern, so we have to select the antibiotic on the basis of this. Or if this is not available, then we have to check for local antibiogram. So what is the common susceptibility of the E. coli in our area? So we have to have a local antibiogram for empirical selection of the antibiotic. Finally, we have to take some patient factor like the renal function and the hepatic function should be taken care before prescribing the antibiotic. And finally, we have to definitively change the antibiotic on the basis of culture result. So we have to send all required culture in the patient. So this is our hospital local antibiogram which we have made for the urine infection. We can see the E. coli, which is the most common cause of the UTI in our region also, but it is found to be quite resistant with the ceftriaxone. There is only 20% susceptibility to the ceftriaxone. So ceftriaxone is not a good choice for an empirical selection of the antibiotic in UTI in our region. So we have to have our local antibiogram to before selection of the antibiotic. So we have to select either piperacillin tazobactam, here we have 92% susceptibility, or we have to see the meropenem, which is 97% of susceptibility. In the ICMR, it is 2019 guideline. The ICMR clearly mentioned that if patient suffering from pyelonephritis, you have to give either piperacillin or ertapenem or imipenem. But in the 2022 guideline, they have changed that empirical selection of antibiotic only be done with the help of these three important aspects. To know if patient already have some culture report in previous 6 months, then have to select the drug from on the basis of this. and you have to also take the antibiotic exposure in the previous 30 days, and you have to have your local antibiogram before prescribing the empirical antibiotic therapy. So there is no definitive guideline for giving empirical antibiotic therapy. So back to our case again. So after 2 days of the hospitalization, we'll get this report. We have given the antibiotic either peptides or meropenem according to the clinical condition of the patient, because ceftriaxone is not a good choice. And we'll get the report of Klebsiella, which is grow in the urine as well as the blood also, and that is resistant. I think it is resistant to the almost all antibiotic. You can see ceftriaxone resistance, peptide resistance, imipenem resistance, aztreonam resistance, and ciprofloxacin resistance. Then what to do? And this is a very common scenario in our hospital. And the microbiologist also written one important thing, that it is an MBL CRE. So what should be the next step? So what antibiotic should be used? There are a lot of options available. So how to select an appropriate antibiotic after getting culture report, or how to select a definitive therapy? To starting the definitive therapy, we have to understand the resistance pattern on the basis of culture result. So as we have said, only 4 or 5 bacteria which we have to know what are the type of resistance pattern. Like in E. coli, the commonest cause of resistance is beta-lactamase production. However, in the Staph aureus, the cause of common resistance is the change in the PBP. PBP is basically the transpeptide enzyme which help in formation of the cell wall, and the beta-lactam antibiotics are going to attach with BPP, and this bacteria will change this PBP to PBP2A, so beta-lactam will not going to attach with this Staph aureus. And third is the pseudomonas, efflux pump or beta-lactamase. So if we have some basic knowledge of the type of resistance, we can select the antibiotic. Like in our case, we'll see, like in our case, it is a case of Enterobacteriaceae infection, and the beta-lactamase is the most common cause of resistance. If you read the microbiology book, they say there's more than 1400 type of beta-lactamase, and there's a lot of classification available. But this is not important for the clinician. So we have to know some clinically significant or important beta-lactamase in the Enterobacteriaceae, and these are the narrow spectrum beta-lactamase that hydrolyze the only penicillins, extended spectrum beta-lactamase that hydrolyzes all the cephalosporin up to the 3rd generation, MC type of beta-lactamase that hydrolyze all the beta-lactam inhibitors like tizobactams and the selbactam also, and carbapinamase that hydrolyzes all the carbapinamase. So by looking the culture report, we can able to detect which type of the beta-lactamase this patient is producing. Like this is the culture reports which this is the crux which we have taken from our culture reports. So we have to see 3 important antibiotic: ceftriaxone, piperacillin tizobactam, and meropenem. If this is then pan-sensitive organism that have sensitive to all the drugs, and this is so the resistance with the ampicillin, means it is a case of narrow spectrum beta-lactamase. This is so the resistance with the ceftriaxone, but not for the piperacillin tizobactam. So likely is a case of extended spectrum beta-lactamase. And this is showing the resistance to the ceftriaxone as well as the piperacillin tizobactam, but not with the meropenem. So likely is a case of MC type of beta-lactamase. And this is show the resistance to the meropenem. So likely is a case of carbapinamase resistance. So by looking this resistance pattern, we can select the appropriate antibiotic. Like a patient with carbapinamase resistance, the newer drug like ceftazidime avibactam, it is a newer BL-BLI combination which is not hydrolyzed by any of the beta-lactamases, it is associated with very much improved outcome. There is a lot of data is available. More newer beta-lactam, beta-lactamase inhibitor combination like meropenem, verobactam, imipenem, cilastin, relebactam, ceftazolone, tizobactam, and cepedaricol. These are available, not available in India, but these are going to be available in India, and they are found to be very much effective in patients with the management of these carbapinamase resistance Enterobacteriaceae infections. While previously we have to give only meropenem in combination with the colistin, and there are comparative study that shows this combination is colistin combination is associated with higher mortality or increased mortality rather than newer beta-lactamase inhibitors. So the meaning of this, that we do not select the antibiotic just basis of just if gentamicin is showing S, so we have to add the gentamicin. No, first we have to understand which is type of resistance, then we have to select the antibiotic for the patient. That will improve the outcome. So everyone is curious about the antibiogram. सबको antibiogram चाहिए. So I think our microbiology department is doing very good work, and So you can go and take your antibiogram of your ward, or you can just calculate the antibiogram of your ward by self. So this antibiogram is calculated by one of the resident in our ward, and they have just accumulated the 6-month culture report and just put in the Excel, and they have calculated the antibiogram. You can also see the E. coli is found to be only 2.7% sensitive to the ceftriaxone. So very much drug resistance, which we have also made this antibiogram of the ICU with the help of simple Excel, or we have a well-developed WHONET program which is available in the microbiology, and we can contact to the microbiology lab. They will create the local antibiogram of their ward or ICU. So this is some examples. So we can see this is the trauma ward GNB's antibiogram. Here the ceftriaxone. The ceftriaxone resistance of E. coli is around 13%. Almost it is highly resistance. E. coli is very highly resistant with the ceftriaxone. So ESBL E. coli is very, very common. This is the example for gram-positive isolates. So this is the first milestone, that how to understand the resistance pattern by using the local antibiogram as well as using the definitive antibiogram of the patient. Second is the guideline. So recently IDSA, Infectious Disease Society of America, European Society as well as ICMR, they have released guidelines as well as guidance for the management of these multi-drug resistance bacteria and how to overcome these resistance. And ICMR has clearly said the newer BL-BLI combinations or higher drugs should be used with the monitoring of Anti-Microbial Stewardship Program, and they should not be used empirically. They should be used for the definitive therapy. So what about our guideline? And this always, as ICMR said, try to follow the local guideline. We have to our antibiogram. So the Department of Medicine in collaboration with the microbiology and pediatrics, we have just formulated a draft of this microbiology policy, and we're going to circulate this antimicrobial policy to all the departments to take the input, and then after taking the input, we're going to release the antibiotic so everyone can able to use. So what we have did till date in the AIIMSP, so we have started the AIIMSP in last 6 months implementation of this program, because surveillance is already ongoing from last 4 or 5 years. So we have implemented the program in the ward, and we have made the AIIMSP committee under the guidance of our director sir and medical superintendent sir, and we have in the process of formulating the local antibiotic guidelines. And we have one core AIIMSP working team that is consist of infectious disease specialists from the medicine, microbiology and pediatrics. And we are also getting fund from the ICMR for one AMS research associate, and one pediatrician is working as a research associate along with the data entry operators and nursing staff. And now we are doing this AIIMSP activities in the adult ICU, in the HD or trauma ICU or medicine ward, and we're going to increase this activity if we have a sufficient number of the manpower. And along with this, we are doing regular academic discussions with the other clinical department, like in the adult ICU with the Department of Critical Care Medicine, Department of Urology, Department of Surgery. We are doing regular discussion to improve how to improve the antibiotic prescriptions, and the infectious disease team is always ready for regular case-to-case discussion, and we are definitely getting the references from all the departments regarding the discussion and selection of the antibiotics. So till date in these ICU and the ward, we have enrolled 1685 patients, and we are getting 6.7% of culture positivity in the ward, and almost 40% culture positivity in the ICU. And as we have discussed, the common organism in the ward, E. coli, Klebsiella pseudomonas, and similarly in the ICU, E. coli, Klebsiella pseudomonas, and Staph aureus, Enterococcus, and CRAB, carbapenemase resistant Acinetobacter. It is very, very common in the ICU and very commonly associated with ventilator-associated pneumonia. So we have started the activity, and we are modifying the treatment. So definitely we want to see the impact, is it actually working or not. So we have done, say, small interim analysis. The effect of triple therapy versus dual therapy. In the new guideline, the CRAB or WAP associate with the Acinetobacter should be managed with the triple therapy. So we have analyzed some data that patients which received dual therapy versus triple therapy, and this is the interim analysis of 75 patients, and we found that the significant survival benefit is associated with the triple therapy. So definitely the interim analysis show the AMSP practices impact the outcome of the patient. So this is the basic about AMSP. Along this AMSP, what else the Department of Medicine and Infectious Diseases are doing regarding the research activity? We are regularly publishing around 50 papers per day in the PubMed, and along with intramural, extramural research, we have accepted around 10 to 15 abstract in the international and national conferences. And we have international collaborations with the snakebite mapping research with the Bangor University, UK. We are doing COVID-19 drug trial with the NIH US and UNSW Australia. And we are also getting the grant for the medical education also. And we are also diagnosing some rare and complicated cases of infective endocarditis and treating them. Around 46 cases we have diagnosed in last 2 years. Extrapulmonary, we have very large chunk of extrapulmonary tuberculosis, which mainly come in the Department of Medicine. We have diagnosed very large number of tubercular meningitis cases, and most of the cases were confirmed with the microbiology, either culture or by the PCR method. Definitely, after the COVID, everyone is talking about the fungal infection. Even before COVID, we are diagnosing lot cases of fungal infection. We have seen almost all type of fungal infection in the different ward, and we are managing these cases. Neuroinfection, along with the common neurological infection, we have also diagnosed some rare CNS aspergillosis cases, and we have also presented in some international conferences and published. And recently we have started the antiretroviral treatment center in this January, and we are providing the comprehensive HIV cares in AIIMS Jodhpur. These are some abstract we have published, and this is one of the abstract that show the rare association of invasive aspergillosis with tuberculosis, which is acknowledged by this international society that this is very rare, but we have diagnosed around 10 cases. And we are also participating in the national conferences. Thank you. So basically, we have just started the MSP program, and almost every person in the hospital or in the institute is the stakeholder of the MSP program. So we're going to increase the MSP activity with the time as the manpower, we increase the manpower. Thank you.
Thank you, Dr. Deepak. Very comprehensive and very elaborated discussions on the AMSP program. At hospital level, it is okay that we are doing so many things, and that is we are propagating about the rational use of antibiotics. But what we have encountered that the patients are already coming with lot of antibiotics for a different durations from outside. So what is the AMSP program role in the community awareness, or how we can target, and which sector of the population should be targeted, whether it is the patients, pharmacies, or the other hospitals? So any role of these community workers or the community setups for the AMSP program?
Sir, the main reason of that everyone is coming with the antibiotic and everyone is taking multiple of antibiotics because of the availability of the antibiotic. Because there is no guideline regarding the availability, who will going to prescribe, and how the pharmacist is going to dispense the antibiotic. Because we require a strong law that not everyone can have access to the antibiotic, and without this approach, we cannot able to stop the use of antibiotic. We just have to give the awareness to the local practitioners. We have to give the awareness to the pharmacist. But I think in India, I think even without a pharmacist or doctor, the patient herself or himself are taking the over-the-counter antibiotics. So the availability of antibiotic is the main issue, that every can have the access to the antibiotic. Or so we require a strong implementation of law that no everyone not able to access the antibiotic, that can reduce the use of excessive use of antibiotic in the community settings, sir. Even in the hospital also, almost every clinician has able to take any type of antibiotic. So this AMSP program is basically that some of the higher antibiotic they have to prescribe in the guidance of the AMSP team. Not the every clinician can have approach to all the antibiotics. And this is the only approach that can reduce the use of excessive use of antibiotic.
Again, there is a question of generic versus branded antibiotics. So again, are we not promoting the drug resistance with the use of generic? Because that is the people maybe less, they will be reluctant to take the branded if there is a available generic, and generic may promote. So is that role of generic also in promoting antibiotic resistance?
There might be because of the generic availability of the antibiotic, the cost of antibiotic is very, very low. So everyone can able to afford to take the antibiotic. One of the cause, because more than 3,000 companies are making the promoting the antibiotics. So very large number of drugs are available with a large number of brands. So this is one of the cause. Again, due to the generic, it is available to the everywhere. And again, increase availability, and there is no law for prescription that increase the use of antibiotic.
This is regarding crab.
Yes, sir.
So as the name suggests, it is inherently resistant to carbapenems, right?
Most of, sir.
Yeah.
Not inherently, but most of crab we are seen is carbapenem resistance.
Crab, as the name suggests, carbapenem resistance.
It is, but it is not, sir. Acinetobacter is not inherent resistance with meropenem.
But
when it is resistant to the meropenem, it is called crab.
Yeah.
Yeah.
So my point is for crab.
Yes, sir.
IDSA guidelines suggest that we should give triple therapy including meropenem,
Yes, sir.
while they are resistant to meropenem.
Yes,
first
sir.
of all. Secondly, in our microbiology lab, all the crabs are reported as meropenem resistant, obviously, but minocycline sensitive. Secondly, and thirdly, though IDSA guidelines suggest to give meropenem, but then they also say that every hospital should have their own antibiogram. So my point is, though IDSA suggests triple antimicrobial therapy, including meropenem, which we know that they are resistant, why can't we have our own? I would rather prefer minocycline instead of meropenem, because microbiology reports, they all suggest that they are sensitive to minocycline first. Minocycline is suggested in IDSA, but as an alternative to polymyxin. Right, but polymyxin, yes, we know that they are quite effective in crab. So till we have our own data, for example, in how many patients have we prescribed triple therapy that includes meropenem, and how many of the patients they have responded to that therapy and not responded, and further we have to escalate further. So that data I would like to have actually before we decide, because see, and every hospital should have its own antibiogram. That is the point. Not blindly following IDSA.
No, sir, we are not blindly following the IDSA. If minocycline is resistance, there is no use of meropenem. No use of minocycline, sorry. If minocycline is sensitive, definitely the minocycline is the drug should be included with the sulbactam and meropenem, because even with the resistance with the meropenem, the use of sulbactam, that will increase the entry of the meropenem in the bacteria, and definitely there is no in vitro sensitivity, but in vitro results are seen in 7 trials. And sir, we are also seeing that we are using the meropenem, sulbactam, either minocycline or polymyxin B on the basis of sensitivity. If minocycline is sensitive, then we are using meropenem, sulbactam and minocycline. If minocycline is resistant, so we are using meropenem, sulbactam and polymyxin. And we are seeing the result that it is found to be effective.
Yeah, I know that.
Yes, sir.
My only point is we are giving meropenem considering that it would be sensitive in combination with sulbactam as per IDSA guidelines. But any retrospective data,
Sir,
how many patients have responded to this therapy?
Sir, I have also discussed with the CMC HOD. He is doing the surveillance program as well as the monitoring of all the culture report. We are also the part of this, and they have said that even with the resistance with the meropenem, it has in vivo effect. Even with the in vitro resistance, the full dose, if we are giving 2 gram with an extended infusion of the 3 to 4 hours, it is going to be effect, and that should be added. And even in vitro data that are found, there are 2-3 in vitro studies in which they have make some pharmacodynamics model, and they have given different of dual therapy and triple therapy, and even these triple therapy, the meropenem has some in vivo effect even with the resistance, sir. There are two large these pharmacodynamic in vitro studies, but so in vivo RCTs are very less and the number is very less. So we require more and more, as you said, we require more and more data to actually conclude that it is very much beneficial or not.
So to stimulate the already two things, just like psychotropic drug and anti-tubercular drug, already government bring in the rule. So every pharmacist must have audit of ATT they given or psychotropic drug. Without doctor prescription they not give. So same age infectious disease society already evolving, they can push for same things. So minimum to start with a drug doctor prescription with their registration number and stamp must be there at every level. So comes some minimum non-clinician or non-doctor cannot prescribe the IV antibiotic especially. Then the third one is we need to separate community and hospital acquired resistant spectrum of the resistant. Then the third one is the dose and duration and route all are important for the effectiveness of antibiotic, especially must be for prolonged duration with proper dilution and proper route. So that is important. So dose and duration and infusion, not a push. Infusion is always important, especially in the pediatric population. So that can help to push for the antibiotic stewardship.
Definitely, sir. As sir, UNSW Australia team came in one of the collaboration in COVID-19, and they have said they have the even only infectious disease specialist can able to authorize the use of meropenem. Below the meropenem, with the ceftriaxone, or they can able to peptide, any doctor can able to use. But above the meropenem, only ID specialist can able to authorize or he or she can able to prescribe this drug. No one else can able to prescribe. So a strong law is definitely required to reduce the use of antibiotic, along with change in the behavior of the clinician also.
So well presented, we have started around 2.5 years back infectious disease DM program. And after starting the program with the pediatrics and microbiology, definitely we have moved ahead, and this specialty has been recognized all over the hospital, and we are doing the wonderful job with the microbiology and pediatrics. We are publishing so many papers and we are getting recognized in India and internationally. As far as the sir was telling in the community, in the last year we had a walk for the antibiotic resistance to make the public aware that they should not consume antibiotic for the small duration of the fever, which is common. Even leave aside the common public, our doctors, even if I say not required, first they will go and take the azithromycin and then they will come to us. So it's become a rampant in the knowledgeable as well as the public. So we have become a habit of writing the antibiotics because that's the easiest way and easiest thing to treat when we become MBBS and MD. कि पेशेंट आए तो एक पैरासीटामोल है, एक एंटीहिस्टामिनिक और एक एंटीबायोटिक, कफ सिरप, ये 4 तो आप बिना देखे लिख दो, भले ही उसको वायरल फीवर हो या URTI हो, which will recover automatically. So now, after so many years, I have become wise. Now I have stopped writing antibiotics. So people say कि सब एंटीबायोटिक तो लिखा ही नहीं, मेरे पास आते हैं पैरासीटामोल लिख दिया, जाओ ठीक हो जाओगे. So it's become एक mindset is required. So that is the very, very important to change the mindset of clinician as well as the common public. And as the law in India, you can make 100 laws. And this law can be broken because there is no control over the pharmaceutical industry. And as you told, 3,000 companies are making. You stop one company, another will come, and they will spurious product will come, and they will keep selling all those kind of the things. So it's become very, very difficult to control, as you are telling, that in India making the law is easy, but to implement such a law, it's become very, very difficult. And I'm really, really happy that at least now we are working on the local antibiogram. In our trauma ICU, in the wards, we are using the rational antibiotic up to the peptide, as you told, we are giving all other antibiotics only on the proven evidence or if the clinical deterioration is there. And as you have seen that in the common wards, we are not getting positivity because patients, they have already taken the antibiotics and they land up with us. In the ICU also, they have taken a lot of antibiotic, they land up in the ICU. And then we get this 5 bacteria, which is difficult to treat and where we concentrate. Otherwise, the rest of the person automatically they recover. So that is very, very important. So well done. And we are doing the good work and we will have the meeting of the antibiotic policy. It is with me. I have to see that antibiotic policy. I will circulate to all HOD and then we will have the meeting and then we finalize the antibiotic policy.
So very well said. My suggestion is that we can make use of this AIIMS Jodhpur nudge unit to create nudge, effective nudge, creative nudge for changing the behavior of both the clinician as well as the general public. One is the awareness program, but the nudging requires some creativity, and with a group of people who are working that, they can create something which can be used as a message or something in a form of infographics or a WhatsApp message for that purpose. So I think we can make use of that nudge unit at AIIMS Jodhpur.
Yes,
Thank you.